Welcome to another episode of eHealth Matters. I'm Aisana, clinical lead for eSurgery, and today I'm joined by Professor Hackett, who some of you may remember from a previous episode on erectile dysfunction. Professor Hackett, thank you so much for coming back and joining me today.
My pleasure.
Lovely. Would you be able to just tell us a little bit more about your expertise in case some of our listeners are not familiar with your work?
Yes, I've been interested in what we call sexual medicine for over 30 years. I'm a past president of the British Society for Sexual Medicine, and I'm on the panel of the International Society for Sexual Medicine. I've done a lot of research, published about 180 papers,
Wow.
of which the majority have been on male sexual dysfunction, but about 30 have been on female problems, which is what we're talking about today.
Yeah.
And I did an NHS clinic for 25 years, but now I work in private practice.
Amazing. Thank you so much for that. So as you refer to as well, today we're talking about female sexual dysfunction. And I was fascinated when I realized that it's affecting up to half of the women population at some stage within their life. So tell me more, what is female sexual dysfunction?
Well, female sexual dysfunction is a blanket term that really covers disorders of sexual desire, what we might call libido, sexual arousal, which is getting turned on, and orgasm, which is the miraculous thing that we all hope for and will be the ultimate part of the experience. And when we consider it, the traditional thing is to talk about a biopsychosocial approach, which means that there'll be biological or medical conditions, there'll be psychological or psychiatric conditions, and there'll be social things about the person's lifestyle and what's going on at work and with family, etc.
Of course. So very similar, would you say it's very similar to how it works for male individuals in terms of experiencing low libido and, again, as you said, the biopsychological impacts on their health?
It's a lot more complicated. I don't think I'll be saying anything that will surprise people to say that women are more complicated than men in this respect. And a lot of that is due to the fact that women have a menopause where there's a dramatic change in their hormone levels, and men don't have a menopause, despite what you might read. 70% of men will maintain their hormones throughout their complete life, whereas 100% of women will lose their hormones at some stage, normally, commencing an average of about age 52. But then even before that, there are issues like contraception, for example. The pill can cause sexual problems because the high levels of hormone estrogen in the pill increase a chemical called SHBG, which is sex hormone binding globulin. And what this does is, because you put a load of estrogen into the body produces more of this SHBG, which actually mops up the small amount of testosterone that women have. And testosterone is the major factor that causes desire in women. So that the pill can have a negative impact on that.
See, so it actually affects your libido so it's basically as a contraceptive as itself, other than what it does physiologically in terms of thickening the lining of the womb, but it also affects your libido. So you're not willing to engage in sexual activity as much.
Yes, a lot of women think going on the pill is going to be the ultimate liberation, that the fear of pregnancy, once that's gone, they'll really be able to relax and concentrate on sex, and it will be wonderful. But unfortunately, this impact on raising their SHBG and lowering their free testosterone level causes a loss of libido. And there's been lots of attempts to alter that by bringing in different types of pill. And then when you move on to HRT, there were different types of HRT that were thought to be more androgenic, in fact, closer to testosterone, that might be better in terms of libido.
Interesting.
But each of those has tended to come with a slightly different complication.
That's really interesting. And just going back to female sexual dysfunction, so it's not just so much not having the libido, but also not reaching orgasm, that sexual kind of satisfaction.
Yeah, we have a sexual response cycle where desire has to be there in the first place.
Right.
And if all the clues are ticked for desire, it's a romantic environment, there's been a bottle of wine, some, a violinist in the background, all these sorts of terrible things we see in the movies. If that's all there and the mood is right, then things will happen and the woman will get aroused. And with arousal comes increase in blood flow to the genital region, engorgement, which then drives lubrication. And that lubrication makes sex more comfortable, more enjoyable, and then facilitates leading to orgasm at the end. There's a few things that can go wrong along the way. So what we've got to realize is that the medical conditions that can affect a man getting an erection, which is the male equivalent of arousal, can also affect women. So if a woman has diabetes, she has high blood pressure, she has high cholesterol, she's had a heart attack, all these things that affect men's erections by reducing blood flow can affect blood flow to the genital region in the woman. But of course they won't be visible, because an erection is there for everyone to see.
Absolutely.
Hopefully not everyone, but it's obvious, whereas it's much more subtle, the disorders of blood flow in women. And in diabetes and with certain medications, the nervous system can be affected so that you get a reduced sensation. And if there's not an adequate sensation, then the blood flow and the congestion won't follow.
This is fascinating, Professor Hackett. As a woman, as a healthcare professional myself, I can't say that not a lot of women know about this. Why is it not talked about? Why isn't there awareness, obviously, about erections and male kind of sexual desires is so widely spoken about, but I mean, I didn't know any of this about how the physiology of the arousal actually works.
Well, the answer really is that it's because there haven't been treatments, and doctors are pragmatic. They like to be able to cure things, or at least treat it. So if there's a treatment, everybody gets excited because there's something that can be done. In the absence of licensed treatments, then you tend to find yourself going over the same things over and over again in talking therapy, and we get frustrated by not getting there. And in fact, it gets worse, because a common response of doctors is to think that the woman must be depressed or anxious, and he prescribes an antidepressant, which of course makes things worse, because that interferes with the nerve messages from the brain down to the genital region. And yet sometimes it's given as a last resort, I've got to do something.
Doesn't that actually work the other way around? Because antidepressant can cause low libido, and they're treating a patient for low libido. That doesn't make any sense to me.
Absolutely. It can both affect libido and it can affect arousal. And these drugs were developed with nobody really looking at this in any of the clinical trials. So these problems only came out years afterwards, because they were only interested in getting a drug that treated depression. They never asked the women the questions, and the women never linked the two and never volunteered the answers.
I suppose it goes back to just not talking about it. Maybe it's because of a social stigma that women just don't talk about what happens in the bedroom. But the finer details isn't discussed. The kind of the arousal parts, the reaching of the orgasm doesn't really get talked about. Should it happen every time?
No.
Okay.
For start, women are much better at talking about these things with other women.
Yeah.
All men talk about is should the centre forward have scored with that header in Saturday's game.
Yeah.
And I've heard patients of mine talking in conversation, saying things like, I've always been a 3 times a night man myself, and I've had to leave the room coughing and spluttering because I've known as a patient that they haven't been able to perform for years, but they get away with it by the jokey lines, whereas women are much more honest and will talk about their problems with friends.
Okay. I don't want our listeners to think, oh my God, I'm not reaching orgasm every time I'm engaging in sexual activity. There must be something wrong with me.
It's variable across different cultures, for example. It can obviously be linked with male performance, because if 30% of men have premature ejaculation and ejaculate in under 2 minutes, it's difficult to imagine that their partner is going to be able to race to orgasm, at the same time.
Yeah, that makes sense. So when would they, for our listeners, when obviously they'll be listening to this podcast, when would they realize, or when do they need to go and seek help for potentially being treated for female sexual dysfunction? What are the signs and symptoms?
They need to seek help when it's causing them distress. They mustn't get obsessed with the fact that Cosmopolitan says that everybody's got to have an orgasm and everybody's got to be doing it 4 times a week, because that's not the real world. So it's really when it's causing you and your partner distress.
Just going back to premenopause and menopause as well, how is this manifested in within that part of a female's life? Obviously, there's a lot that goes through when you're going through premenopause and menopause as well. Why is it so important to look at the symptoms as a whole picture and not stick a woman on HRT, for example, but to look at, as you said, the arousal side of things as well?
Absolutely. The doctor's got to take a better history and not sort of think that HRT is going to be the cure for everything, because in my experience, a lot of women are there because of the sexual problems, and they think that it's the menopause and that the HRT will cure everything, or they hope. And so it's important that the doctor, in taking the history, works out whether this is a primarily desire problem, whether it's an arousal problem, or whether it's an orgasm problem, or indeed might there be an overlap of 2 or 3 of them, because that's the best way to direct the appropriate therapy.
Right. And from your experience, does this actually happen in reality, in day-to-day practice?
I'd be very surprised if it happened in general practice, but if someone went to see a specialist in sexual medicine, then it would happen. But they tend to rely on their gynecologist, who's usually a surgeon, who hasn't really got the time to delve into that sort of thing. They could see a psychosexual therapist who'll be trained in the medical side of things, not just the psychological. But that is unlikely to be available readily on the NHS, so they might have to go privately. But I agree with you that there's not a large number of healthcare professionals available to help, and that's largely because the NHS isn't funding this as a priority.
Right. And is there funding into research in female sexual dysfunction?
We talked about testosterone earlier and how important it is in terms of sexual desire. Women have about 1/10 the amount of testosterone that men have. But that 10th that they have is vitally important, particularly when they lose that at the menopause. And the problem with what you say is that the studies that were done on testosterone were done years ago, because after all, that's the male hormone. There weren't any studies on estrogen done in men.
Yes.
Why should they? But we actually know estrogen's quite important in men. So as a result, the testosterone products were licensed, and the product license of a drug lasts 15 years. And then it goes off patent and it becomes cheap.
Right.
Now, there's no motivation for pharmaceutical companies to do large trials that might cost £50 million each for a drug that's already become generic, because women only need 1/10 the amount of men. So that's the basics, that there's no money to fund trials for something that's now become essentially cheap. But women can use lower doses of the male formulation. For example, what is offered is that a sachet of testosterone gel, for example, which would contain 50 milligrams, the female dose is 5 milligrams. So what they're told to do is to get a syringe and draw up 1/10 the dose, seal the sachet with a paper clip, and that will last them 10 days. And that will be very, very cheap, very messy. Your alternative is to get a pump dispenser where the male dose is 4 pumps or 5 pumps a day. You do 1 pump, you divide it with a ruler and get rid of half and use half. That again will be very cheap. There is a licensed preparation that's been available in Australia for 2 or 3 years, which is going to be licensed in the UK next year, which is called Androfem, which is a specific product for women.
So which resolves the fiddling around with the doses, because I can imagine it can be really, really frustrating when you have to kind of open, as you said, open a sachet and then just divide up the dose as well. So hopefully that will...
The problem will come is that it will be 10 times the price. And will the NHS pay, or will they recommend the cheap approach?
I think we both know which one it will probably end up with.
The real positive news, though, is in terms of arousal, because, as I mentioned, arousal can be related to the same sorts of conditions that cause erection problems in men. If you've got high blood pressure, raised cholesterol, diabetes, you don't get enough blood into the vagina, into the clitoris, pelvic organs, to be able to become congested and lubricated and get adequate sensation. So the drugs that treat erectile dysfunction, sildenafil, which was Viagra, and tadalafil, which was Cialis, have been shown in trials to be highly effective in women in increasing arousal. If they've got desire, then they haven't got the desire to get aroused. You need the desire treated. And that was the problem in all the trials in women. There was no adequate way of sorting out the women who had normal desire to give them a drug that would increase their arousal. So they searched for women who had exclusively an arousal problem. And the drug worked pretty well in those. The reason why tadalafil or Cialis is better is because it's known as the weekend pill. So therefore it works for 72 hours. Viagra or sildenafil works for 4 hours. So therefore taking Viagra means that the woman has now got to really orchestrate the sex. Whereas if she takes tadalafil or Cialis, she can take a small dose every day and she can be available to be aroused whenever the time is right. It doesn't even need a partner. She can arouse herself, which is a subject that is often ignored, because a woman's sexuality isn't all about what she does with hubby on a Saturday night. So that's what's become really exciting. And the good thing about it is that here we have a drug that is now generic. It's cheap. It's about £3 a month. It has been used in women for over 20 years because it's licensed to treat a condition called pulmonary hypertension, where you take 40 milligrams a day. So if it's been safe for 40 milligrams a day, it's certainly safe at 5 milligrams a day. It's also great for some other conditions, because if it gets blood flowing, then it will help other conditions such as Raynaud's syndrome, cold hands, cold feet, which affects women much more readily than men. It also has been shown to improve mood and help with prevention of dementia. Well, now you're really talking, because women get more dementia as they get older than men do. And unfortunately, women often get antidepressants because nobody else knows what to do. So this is really very exciting.
And is this readily available through the NHS, you say?
It's available to be prescribed on the NHS.
I'm aware with erectile dysfunction medication for male patients, there are certain kind of criteria where the NHS would actually fund that patient's prescription. Otherwise, they say, no, you have to have it on a private prescription. Would a female patient will still be able to go to their GP and say, I'm happy to pay for this privately, I still need you to prescribe it for me?
Well, those rules were drawn up when it was £6 or £7 a tablet. Now that 28 tablets are £3, and the patient's probably paying £10 for a prescription, it's clearly ludicrous. And those have largely gone. They've gone for sildenafil. Sildenafil can be prescribed freely.
So we talked about all the positives or the benefits of this tadalafil for female sexual dysfunction. How about the kind of contraindication? Who shouldn't be taking this medicine? Who is it not suitable for?
Well, this is where good news. We know that it's very well tolerated, particularly in this lower dose. In terms of side effects, it's about 5% of patients can get indigestion, slight acid. Tends to be people who've already got that tendency anyway. You can get a headache with the higher doses, but with the lower doses you don't get it. And incidentally, I found it a very good treatment for women who get frequent headaches, because a lot of headaches are due to rebound relaxation of the arteries, and that stretches the nerve endings in the artery wall. If you have a drug that's in a low dose is gently dilating your arteries on a daily basis, you don't get the extremes that give headaches. And I found a number, usually male patients, because I've got more experience with them, who said they don't get headaches once they go on the daily tadalafil. And I have seen women reporting the same thing. But that, of course, would be an off-licensed indication.
Fair enough.
So the only thing is there's a contraindication for them to be taken with nitrates. Now, nitrates are tablets or sprays used for angina. So that's going to be a very, very small number of patients.
Interesting. And how about, I'm just going to go back to menopause once again. Shouldn't this be almost like a package, like a whole combination of treatments that once you kind of have your consultation to have HRT, you almost have, based on your symptoms, of course, you have the testosterone, you have the tadalafil, you have your HRT patches. Do they all kind of go hand in hand?
You've hit the nail on the head, yeah.
Okay.
And this is where the private menopause clinics are really cashing in, because they started out with just the HRT. They really achieved most of their success by realizing that testosterone was at least as important, and it was giving the testosterone that really corrected the symptom that most women were looking to have improved, which was their libido. And the conventional HRT hadn't delivered on that. And so then it unmasked the problem that there might be an arousal issue. So the logical thing is you add in the tadalafil, and that way you retain your patient base who come back time after time for long-term follow-up. A lot of the problem is we're not rewarding GPs for this, because GPs get paid a certain amount for each patient, and they don't get more per orgasm that the patient has.
Of course.
So therefore, they just haven't got the time, but I spend most of my time speaking to them saying, look, treating these issues has given me more pleasure, more feedback from patients than I ever saw when I treated their cholesterol.
Yeah.
Aren't we in this job to make patients feel better and to have patients shake our hands and embrace us in the street?
Yeah. It's really hard. I mean, I'm sure no kind of doctor goes into the profession, or hopefully none of them, to kind of go, yeah, I'm going into this to basically hit my tick box exercises. They want to, as you said, to make patients feel better. But unfortunately, when they have the 10-minute time slot, the hands are tied, right? So they have to see patients, and to be able to give the patients an overview of all their symptoms, or hear them say an overview of all their symptoms, it can be quite difficult within a 10-minute time slot.
It can be impossible in a 10-minute time slot.
Yes.
Particularly if it's a woman with 2 small children that she's brought in as well.
Absolutely.
Which is why it becomes quicker to write the prescription for the antidepressant.
Absolutely.
Because when we were talking about the biopsycho, there's a social side as well. That it's very difficult for a woman who's got children at home screaming the whole time. She's not getting any sleep. They're short of money. Husband's out of work. You know, that these are problems that aren't going to be solved by either some testosterone gel or tadalafil.
Absolutely. And that is the reality of a lot of women's life, really.
Yeah.
That is what they go through. And then by the time that they go through raising their children, you know, as you said, go through the struggles of daily life, they hit menopause.
Yes, so those problems probably need governments to solve them.
And what advice would you give in terms of lifestyle? Is there any lifestyle factors or holistic approaches that patients can take if they didn't want to pursue taking a tablet every day, such as Cialis?
Well, I don't see it as an either or, because I think even if you're taking the tablets, lifestyle's got to be addressed in every single patient.
Absolutely.
As has the relationship. Because if you've got, but in terms of what they can do to improve themselves, obviously, if they're unfit, it's very difficult to be able to have good sex if your back aches and your hips won't move and you can't get comfortable. So therefore, getting yourself fitter, losing weight will obviously help, because that can be a barrier, not only in actually having sex, but the image problems that, you know, image is almost the biggest thing in society at the moment.
Yes.
You know, it's how you look, not how you are as a person that seems to matter most. So you've got to address these things. There's in terms of what other things they can do, I think obviously if they're anemic, then get that looked at. If they've had a baby recently, then they might have problems with healing up afterwards, or they might have lax vaginal tone, so they might be helped by doing some vaginal exercises. Seeing a physiotherapist might help them to tone up the muscles, because if the muscles are lax, you're not really going to get the arousal or the orgasm. In terms of vitamin supplements, I think I don't know of anything that's specifically helpful in that respect that I can recommend.
Or at least not evidence-based.
That's not
perhaps.
evidence-based, because I find whenever I do that, it usually backfires on me. But if they found something that they've read in a magazine and it works, then I always encourage them.
Yeah, fair enough. How about what we didn't touch up on, and we mainly focused our discussion around a female who's in a relationship with a male partner. How about a same-sex relationship? How would the kind of the dynamics of this change?
Very important, because unfortunately all the trials, even on the Viagra and Cialis, were done based on things like the IIEF, which was about heterosexual people having intercourse. The similar things like in women, the FSFI, have all been validated heterosexual couples.
Right.
So limited work has been done for clinical trial purposes, specifically in these groups. And the reasons were hard economics, really, because they were viewed as being the minority group, very expensive to do specific trials in them. They were worried that the endpoints might be different and might water down the response they were getting with heterosexual couples.
Yes.
Because if you've got two women, then they're likely to have FSD themselves.
Yes.
So who are you treating? You've got to treat the two simultaneously who might not have the same condition.
Yes, that makes sense.
And of course, the problem has always been, whereas an erection is easy to assess, these changes in vaginal engorgement, lubrication, orgasm are much more subjective and harder to repeat in clinical trials.
I'm glad that you touched on this as well. So when it comes to almost diagnosing erectile dysfunction, am I right to assume that there are specific tests that a clinician would kind of perform or conduct to diagnose a patient with erectile dysfunction, but there isn't specific like tests that they do for a female patient?
Yeah, with a man, you can give them an injection to induce an erection. You can do various sorts of Dopplers, scans, MRIs, color duplex ones, because you're looking at something that is easily reachable. With women, what you've got to do is you've got to put probes inside to be able to measure blood flow changes, fluid changes, and that's more intrusive. It's hardly a natural thing to be doing.
Of course.
There's things called vaginal plethysmography, where you can actually put a probe in, and you can actually get measurable scores of engorgement. They've had couples having sex in MRI scanners, which is
very off-putting.
quite confined space, where they've been able to show the vaginal engorgement, and also lubrication can be measured with filter paper, etc. And pH changes can be measured that way, but they're not as, dare I say, good hard endpoints.
I see. So is that one of the reasons why it's much harder to do or it takes longer to diagnose someone with female sexual dysfunction, whereas it's obviously more visible in a male patient, whether they are erected or in the absence of a, pretty much you run some tests, some blood tests, and then it's much easier to kind of do the diagnosis and finding the underlying cause, whereas with the female it's much more complicated, and possibly why GPs don't have the time to really get into the underlying condition.
And for example, there's a 4-question IIEF, 4 and a 5 version, where you can just hand it to the patient and he'll go tick, 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 hand it back to you. With the female one, it's the shortest one is 15 and another one's 30, and you virtually need a manual with you to be able to interpret the results because of the complexity of the desire, arousal, orgasm, and picking up some other things about their history.
Absolutely.
So it doesn't lend itself to assessment in the clinic as readily.
Right, okay. And it's mainly the kind of, as you said, lack of desire, the lack of lubrication, and what was a couple of more specific symptoms? Engorgement as well. Okay.
If you speak the right language, once you begin to use these terms, the patient can understand what you mean. They understand what feeling horny means, and they realise that in a long-standing relationship, there's probably not so much horniness. That the sex has become a little bit dull and repetitive. You know, it'll be after match of the day if the team's done well, sort of thing.
Yeah.
And that obviously isn't what she's been looking for.
Yeah.
And so you've got to try to get round that. And so you have discussions about date nights, you know, getting the children out to somebody looking after them, you know, to actually go back to the things you did when you first found things romantic.
Right.
And sometimes just suggesting that to people can make a big difference. And you don't need to be a sex therapist to do that. It's just common sense.
Just make it happen. Like give yourself and your partner time.
Yeah.
Yeah. And I mean, it was interesting because when I was going through the symptoms and the absence of lubrication, and it made me think what it actually means. Like if I said that to a patient, they probably wouldn't understand it. So how would you describe that to your patients?
Well, you can talk to them about being wet.
Okay.
You know, and are they conscious that when they get aroused, they get wet? And so it doesn't have to be with penetration.
Right.
And it's a good sign if it occurs before any penetration. And if they've got, for example, as I said, diabetes or heart disease or whatever, because you need blood to be flowing to get the glands stimulated, to get lubrication, then they might need some artificial lubrication. So you either have a water-based or an oil-based preparation, and the water-based ones are more agreeable. But if you have two, if the man uses a lubricant and you have a water and an oil-based one, you can get what therapists describe as a double glide sensation, which is increases the level of eroticism, which some patients appreciate. There's a clitoral, a bit of Ovismen cream around the clitoris. There's a clitoral engorger, like a vacuum device, that can be used to, if the clitoris is atrophic, to actually increase the blood flow to there.
I see. And how would a woman usually communicate this to their partner? Like how would the discussion go? Is this something from your experience that both partners come to you and it's something they've already spoken about, or the woman comes to you and says, I'm having difficulty and I don't want my husband to know, it's affecting my relationship? How does that usually work?
Well, this is a very important issue, because in the NHS, women tend to go to gynecologists and men tend to go to urologists.
Yeah.
And they go on their own. And I think a lot happens that when the guy goes to the gynecology clinic, he's going to feel he sticks out like a sore thumb there.
Absolutely.
Why is he here? You know, so we've got to change that environment. And that's where the concept of sexual medicine comes in, because that's very much about couples.
Yeah.
So we need to get them going together, because it works both ways, because sometimes the man needs to be, as he gets older, he needs more arousal than he did when he was in his 20s.
Yeah.
And he finds it impossible to tell his partner to do that.
Yeah.
And likewise the man, if he learns what his partner needs to get aroused, he'll be only too pleased to cooperate.
Of course. Would you have any advice for a couple who may be going through this? How would you advise them to talk to each other?
I would think often something like the internet or a television program is often a good way, because there's a lot of the programs on late at night when the children have gone to bed, where often when they come on, there's a bit of embarrassment, you know, should we switch this off and see whether there's some football on the other channel? Yeah. But if you find that your partner actually wants to watch it, that's a good way of learning. It gives permission that these things, if they're on a television program, it's important enough to be talking about.
Right, and it gives them a way to discuss their own possible kind of issues that they're having as well.
Yeah.
Gives them a way.
rather like that
Oh,
Embarrassing Bodies program.
Yes.
That I can remember being asked to be on it, and you'll be pleased to know it was as a doctor, not as an exhibit.
I was just going to say, I'll go and search the internet now.
That we almost need, a good sex doctor program would be a great help.
Yeah. And why don't they have one? Why doesn't anyone talk about this?
Well, hopefully somebody will be listening to us today.
Hopefully. I really hope so.
I am available. Yeah.
So where do you see the future of female sexual dysfunction treatment leading? Where is this going?
I don't see any new drugs coming to the market, particularly in the UK.
Right.
I mentioned one in the US. If it hasn't happened in this time that's had available, I doubt whether it's going to happen. I don't think it's going to become a priority. I keep looking at our health minister and seeing whether his statement is going to come out that sex is going to be a priority, but I've got no signs of it yet. So I think it's going to, I can see it developing because with the British Society for Sexual Medicine, our membership is growing all the time.
Yeah.
We do a series of webinars for both men and women, for doctors and healthcare professionals, and we're now up to about 150 for each session. We do 2 meetings a year, and there's similar number, 150 doctors attending each.
Right.
So the level of training and knowledge is going up, and I think I can see in the doctors that I'm training, more of them realizing what I got out of it, and that it's pretty boring if you're just managing cholesterol and blood pressure.
Yeah.
But talking about this stuff to people that really matters, and as I probably said earlier, you're not going to get a woman embracing you in the supermarket because her cholesterol's gone down from 5 to 4. But if she and a partner have started having sex regularly, I regularly get embraced in the queue at Lidl, which I'm quite pleased with.
That just kind of put a picture in my head from a TV show where, they had, this couple had great sexual intercourse, and they were both kind of just, walking the streets, big smile on their faces. And it just makes me think, surely this would help mental health as well. If you're sexually satisfied, surely it helps within your self-worth, maybe?
Absolutely.
Okay.
Yeah, there's good evidence for that. But unfortunately, it's not something that's looked at by psychiatrists often enough. Hinted on earlier, they seem to be hell-bent on giving drugs that destroy sexual function.
Yeah.
And I'm left a lot of the time saying, well, it's not going to get better whilst you're on this drug. Yeah. Can we not change it? And the psychiatrist won't bend at all. They just see controlling the psychiatric or psychological problem. Yeah. And this is a problem in medicine. We're so compartmentalized. Yes. Nobody can look at the bigger picture as to whether your medication might be making something else better. Yeah. That's another doc's job for another day.
Yeah.
I've only got 10 minutes to deal with my problem.
Yes, and then you get the pharmacist coming in doing medicine management, and then they look at the whole thing and they're like, what is this poor patient on, taking all these medication from different doctors? So I see that. One
of the interesting things is that pharmacists are getting on board. Pharmacists are becoming the main port of call now for erectile dysfunction. We're doing tutorials for them. They've all got their side rooms where that you can go and talk to them.
Yes.
This is probably the most promising port of call for women, but they're not going to spend much time talking to women if there's no product going to be prescribed at the end of the day.
Yeah, absolutely. And the Cialis over-the-counter is licensed for male patients only, so unfortunately, it's not available to women. Is that right?
It's licensed for men because the trials only involved men.
Yeah.
This is crucial here because Cialis is a named brand.
Yeah.
A named brand cannot say that they can be used for anything else unless they've got the trials.
Right.
Once something becomes generic and can be made by 50 different companies, there's no body going to be held out to dry if these comments are made?
Yeah.
Which is why, and when they become generic and over the counter, it's no different from the pharmacist saying, here's some selenium tablets. I found that they're great for making your toenails grow straight. Nobody's going to contradict that because there's no named product that he's pushing.
Could you see that happening? For example, like having a PGD for a community pharmacy, prescribing tadalafil for female patients?
I can see it happening because we're at the moment trying to get a clinical study going to show cardio prevention in men and women. And our problem has been we've got to keep the budget so low. So we need a lot of people in it. And the budget's got to be low because there's no drug company money to fund it. It's got to come out of government research funding. And our major worry is that we're going to go down to the bare boards and make it a low budget trial, and it'll be inconclusive because we cut too many corners.
Yeah, that makes sense. Thank you for that. If you could give one key message to women listening who may be struggling with low libido, what would you say?
I would say find a healthcare professional to talk about it. Talk about it with your friends, but find somebody. It might be a practice nurse. It might be a nurse who deals with your HRT, your contraception. Failing that, I think it's such an important thing. Find out an expert and pay for a private consultation because, if you've got to spend £200, I can guarantee that your divorce will cost you a lot more than that.
It does, absolutely. Well, thank you so much for that, Professor Hackett. It's been an absolute pleasure and so interesting to learn about female sexual dysfunction. Thank you for joining us today.
Thank you.